We are live now, ma'am.
Oh.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Benign Gynaecology, organized by Clinical Research Committee, OXY with FOXY. So it's my privilege to introduce the MOC of today's webinar, Dr. Deepa ma'am. Ma'am is the consultant at Thamare Fertility Solutions, Chennai, Joint Secretary of ATN RCOG, and Advisory Committee OXY 2023 to 24, Chairperson OXY 2024 Clinical Research and Quiz Committee. I welcome you, ma'am.
Thank you, Sakati. Thanks for the nice intro. Dr. Priya is my co-convener today. She is a co-chairperson CRC committee. She is a fertility specialist as well as a quiz master for the today. And I welcome our secretary, welcome Ramani madam and our secretary madam to do a welcome address. Today's topic of presentation is like benign gynecology is the theme. And we are doing a journal club on this, two topics from the benign gynecology, two topics from endometriosis. I welcome Ramani madam and our moderators, Dr. Uma, as well as Dr. Raja Rajeshwari. And we'll start with lamp lighting. Thank you. Next, we'll ask Geeta madam to do Oxy prayer. She is our secretary. She is in the government UGPG teacher for a long time, and she is currently attached to Chengalpattu Medical College. Over to you, madam.
Thank you, Dr. Deepa. First, we should thank the Almighty for giving us the opportunity to do this journal club. So we'll go on with the prayer. Thank you, God. In humility we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. So with this, it gives me an immense pleasure as a secretary of OXY to welcome one and all for this journal club, which has been conducted by the Clinical Research Committee of OXY, the chairperson and co-chairperson, Dr. Deepa Thangamani and Dr. Priya Kannappan. And we also have the FOXY chairperson of the Clinical Research Committee, Dr. Surekha madam. And it gives me an immense pleasure to invite all the experts, moderators, and the speakers of this journal club. And today's topic being benign gynecology. I really appreciate Deepa Thangamani and Priya Kannappan for selecting this topic and finding a right person as an expert, Dr. Ramani madam, on the topic of endometriosis. So,
we also have
with this,
sir.
Yes, Dr. Kiran Koti is also there as a expert, and it's very nice to welcome you all. And we will go on with the journal club, and over to Dr. Deepa.
Thank you, madam. We'll ask, can I ask Dr. Surekha, our FOXY chairperson's Clinical Research Committee, to give a small introduction about the topic as well as to welcome us.
Thank you very much. Thank you, Dr. Priya and Dr. Deepa, for convening these journal clubs, which we are having since almost now 1.5 years. And we are doing this every month. And it does take a lot of efforts to organize and select the topics, to select the experts and the moderators, the presenters. So I must appreciate both of you. And I would also like to thank our Foxy office bearers, Dr. Jaideep Thank and Dr. Madhuri Patel, Dr. Charmila, for supporting this endeavor. And we all know about, the continuity. This journal club started along with Foxy and Oxy when in Dr. Pai's tenure, but we do have this continuity. So that again gives us the scholarly attitude of both organizations, Foxy as well as Oxy, and involvement of members. And today's topic is very, very apt. Benign disorders. We do have the experts, Dr. Ramni Devi and Dr. Kiran Kurtukoti, sir. He is the president of AMOX, Dr. Ramni Devi, president of TNFOG. And we do have these two topics, the role of Dynogest in endometriosis and ASHRAE guidelines on endometriosis. Thank you to the moderators, Dr. K. Uma and Dr. K.S. Raja Rajeshwari, and the presenters, Dr. Laksha and Dr. Kiruba. Thank you, the Oxy President, Dr. Vijaya and Dr. Geeta Lakshmi, for continuing every month this very beautiful programs. And I would like to again thank our experts, and over to you, Dr. Priya, to continue the proceedings.
Thank you, Madam, for such a kind introduction. Sureka, Madam, can you introduce Dr. Kiran, sir, please?
Yes, it is my pleasure and my honor to introduce our president of AMOX. AMOX is our All Maharashtra OBGYN Society, and Dr. Kiran Kurtukoti is a very, very dynamic president. Since he has taken over as the AMOX president, there has been such a lot of new, programs being undertaken, initiatives, and few of them I can just from straight away narrate, like anybody can practice ART, anybody can practice, I think, endoscopy and ultrasound. Such good initiatives have taken, and all the committees are working very well, sir, under you. And every day we find new initiatives. He has been the chairperson of MTP committee, and he has led many initiatives.
Thank you, Sureka. Dr. Sureka, that's
thank you.
Thank you so much. Thank you so much. Thank you so much.
Thank you, sir. Thank you. So can we have the next series, please? Geeta, Madam.
Yes, Ramni Devi, ma'am, as well.
Yes, ma'am. Can you introduce Ramni Devi, Madam, please?
Yeah, so we again we know Dr. Ramni Devi. She is presently the president of TNFOG, but we do know her as a stalwart. She has been doing such a lot of work on endometriosis. She has done a PhD as well in this topic, which is again a great achievement. And National Vice President of Foxy in 2020, and International Expert Advisory Board member of Fertility Society of Bangladesh, and ICOG Governing Council member. Madam is now going for elections for the Vice President of ICOG as well. Madam, we do know that all the accolades and all the focused work which you have done on endometriosis. When we think of endometriosis, and when you think from any face from India, the first name which comes to anybody's mind is Dr. Ramni Devi. So that explains it all. So, Madam, we are very much honored that you are here for today as an expert for the discussions.
Thank you, Sureka, for your kind words. Really, I'm honored to be here with all of you for this journal club.
Thank you,
ma'am. Priya, shall we move on to topic?
Yes, ma'am. Like we will introduce our experts for today, madam, our moderators. I would request Geeta Lakshmi, madam, to introduce our moderators for today's session, madam. Geeta Lakshmi, madam, are you there, madam?
Irukanga. Madam was there.
Ma'am, your voice is not audible, ma'am. Geeta, ma'am.
Geeta, madam is muted. No.
Mute illa, but கேட்க மாட்டேங்குது.
Okay. Ask her to check the volume. Volume of her.
Madam, we are not able to hear. It's okay, madam. I will start introducing. It is my pleasure to introduce Dr. Uma Kalyanasundram, madam. Madam is the head of the Department of Obs and Gyne of Sundram Medical Foundation. She's been an MBBS and postgraduate from Seth GS Medical College and Chem Medical College, Mumbai. And she's been member of various societies, presented paper, poster, and national international conferences, faculty in all UG and PG revision courses. She has a special interest in high-risk obstetrics, subfertility, endoscopy, and academics. So Uma madam is a DNB teacher. We all know her very well. So next, can we have the next CV, please? So Dr. Raja Rajeshwari madam has done her MBBS from Coimbatore Medical College and MD from MMC. And she's a member of the Royal College of Obs and Gyne. And now she's an additional chief of the Southern Railways Hospital, Headquarters Hospital, Perambur. And madam has been the DNB teacher and examiner for DNB with special interest in gynae, endoscopy, and infertility. So can we have the first session speaker? So the first session will be by Dr. Lakshya Kannadasan. She's a junior resident, Sundram Medical Foundation, Chennai. The topic will be for role of gynecology in endometriosis in young women. So yes, Dr. Lakshya is a junior resident in Obs and Gyne of Sundram Medical Foundation, MBBS from Chengalpattu Medical College and post-graduation in SMF, and has been presented papers in different conferences. Over to you, Dr. Lakshya.
Sorry, Priya, can you hear me?
Yes, madam. Yes, sorry.
I had a connectivity issue. I welcome Ramani madam and the moderators, Dr. Uma madam and Dr. Raja Rajeshwari. So now we'll go on with the presentation. Okay.
Thank you, ma'am.
Thank you.
Thank you.
Dr. Lakshya, yes.
Okay. Am I audible, ma'am?
Yes, yes.
Okay, I'll start the presentation.
Yes. Thank you.
Good evening. Good evening to all the delegates and the consultants, my colleagues, seniors. I'm Dr. Lakshya. I'm a final year OB/GYN resident at Sundram Medical Foundation, and I would be presenting about endometriosis in the young, dilemma in treatment. So endometriosis is an estrogen-dependent disease. It is the ectopic growth of proliferative endometrial tissue outside the uterine cavity. It is characterized by pelvic pain, dysmenorrhea, dyspareunia, and subfertility. Endometriosis-associated pelvic pain is the most common complaint of patients with endometriosis, and 70% of the women with just a second. 70% of the women with endometriosis present with EAPP, and endometriomas are found in about 17 to 44% of the patients. So the topic I would be presenting is a journal article which was presented in the Journal of Obstetrics and Gynecology of India in September to October 2021. It is the role of gynecologists in endometriosis in young women by Renuka Malik and Manmeet Kaur-Mann. So it was a prospective observational study done between November 2018 to December 2019 in the Department of Gynecology, ABVIMS, and Dr. RML Hospital. This study was on the effectiveness of gynecologists in young women, and 56 women of the age group 15 to 35 years were enrolled in the study, and women who had complaints of pain and were diagnosed with endometriosis either laparoscopically or by imaging were recruited. The inclusion criteria were women between 15 to 35 years of age who were diagnosed with endometriosis either by imaging or by laparoscopy, and endometriomas of size less than or equal to 8 centimeters. Exclusion criteria were women less than 15 years of age or more than 35 years, and endometriomas of size more than 8 centimeters were excluded in this study. So patients that met the inclusion criteria were given Dymagist 2 milligram once daily, and the effect of treatment was noted in the resolution of pain and in the reduction in the size of endometriomas over a period of 3 months. Patients were followed up at 1 and 3 months. The baseline investigations that were done were kidney function test, liver function test, and pelvic ultrasound. These were repeated at 1 and 3 months again, and side effects, both minor and major, were looked into at each follow-up. So 56 patients that enrolled in this study, they were first assessed, they were first given a pain score of about 0 to 10. They were asked to say the pain of their situation, and then followed by which we took a detailed history, including previous medical and surgical history, and clinical examination was done. Biochemical investigations like LFTs and RFTs and ultrasound was done for looking into the endometriomas. So if they met the inclusion criteria, they were enrolled in the study, and all the baseline assessment was done, and they were given Dynogist 2 milligram once daily dose, and they were again followed up at 1 month. Again, their pain was reassessed using the NRS score, which is the numerical rating score, and they were asked to score between 0 to 10. The biochemical investigations were repeated, side effects were noted, and ultrasound was done to see any change in the endometrioma size. This was again done at 3 months, and then followed by which the data was compiled and a statistical data analysis was done. More than 30% pain reduction was seen as a significant pain relief on treatment, and more than 50% regression in the size of endometrioma was considered a significant reduction in endometrioma in this study. The characteristics of study population were 75% were in the age group of 21 to 30 years, 14.2% were in the age group of 15 to 20 years, and 8.9% were adolescents less than 90 years. And 59% of them were unmarried, 71% were nulligravidas, 11% were primiparous, and 18% were multiparous. Out of the 40 nulligravidas, 7 patients had primary subfertility, 92% were diagnosed by ultrasound alone, amongst which 59% were by transabdominal sonography and 41% by transvaginal sonography. 3.5% were diagnosed by both MRI and ultrasound, and 3.5% were diagnosed by ultrasound and laparoscopy. And all of the patients recruited for the study had EAPP and endometriomas. The intensity of the pain were assessed using the numerical rating pain scale, NRS scale, and they were classified as mild, moderate, and severe. Mild were between 1 to 3, moderate was between 4 to 6, and severe pain is between 7 to 10. So out of the 56 patients who were recruited in the study, 73% had severe pain, 25% had moderate pain, and 1.7% had mild pain. 77% of them had dysmenorrhea, 10% of them had dyspareunia, and 3.5% had dysphagia. And looking into the endometriomas, 66% had endometriomas less than 4 centimeter in size, 34% had endometriomas between 4 to 8 centimeters, and endometriomas of more than 8 centimeter were excluded in this study. So relief of pain, regression of endometriomas, and side effects were noted at 1 and 3 months. Moving into the pain relief, 67.8% had pain relief within 2 to 5 days of starting treatment. 17.8% had pain relief within 6 to 10 days, which means that approximately 86% of them had pain relief within the first 10 days of starting treatment, and 14% had pain relief after 10 days of starting treatment. So after 1 month of treatment, 73% had significant pain relief, and out of 41 patients who had severe pain at enrollment, only 1 patient was left with severe pain at the end of 1 month with Dynogist. So this is the assessment scale that was given, amongst which there were 41 patients who had severe pain at the enrollment. And after giving Dynogist, after 1 month of treatment, only 1 patient was left with severe pain at the end of 1 month and at the end of 3 months. After 3 months, 13 patients had mild pain, 42 patients had moderate pain, and only 1 was left with severe pain.
What is going to happen in the other? What we are seeing now, practices where there is reduction in the
Moving on to the reduction in the size of endometriomas, successful reduction in endometriotic cyst was seen in 3 patients at the end of 1 month of Dynogist. At the end of 3 months, 7 patients had significant cyst size reduction with Dynogist. 42.8% of them had no reduction in the size after 3 months with Dynogist. 44.6 patients had less than 50% reduction in the size of the endometriomas. And only 5 patients had complete disappearance of the endometriomas, and all of them had endometriomas of size less than or equal to 4 centimeters. So when you look into the diagram on the right end, you can see that the mean reduction in the size of endometriomas at enrollment was about 3.12 centimeters. It only reduced to 2.63 centimeters after 1 month and 2.45 centimeter at the end of 3 months. Moving on to the side effect profile. The common side effects that were noted after the usage of Dynogest were LUBs, amenorrheas, breast pain, headache, acne, and bowel disturbances. These were all the minor side effects, and the major side effects that were noted were thromboembolic episodes, deranged LFTs, and deranged KFTs. After the treatment, at 1 month, 25% had LUBs, none of them had amenorrhea, 14% had breast pain, 5% had headache, and 5% had acne, which was a similar profile after 3 months as well. And none of the patients had any major side effects. So to conclude, in this study, there was significant pain relief in about 73% at the end of 1 and 3 months of Dynogest. And at enrollment, the mean NRS score, which was 7.4, gradually reduced to 4.3 at 1 month and 4.29 at 3 months of Dynogest usage. And significant reduction was considered in this study as more than 50% regression in the largest dimension. Using those criteria, there was not much reduction in the size of endometriomas, but no further growth in the size of endometriomas was seen in any of these patients. And no major side effects were noted, and no patients discontinued Dynogest because of the side effects. So moving on to Dynogest. Dynogest is a synthetic oral progesterone. It is a 4th generation progestin which binds to the progesterone receptor, and when taken continuously, it inhibits the systemic gonadotropin secretion. It has local anti-proliferative and anti-inflammatory effects on the endometriotic lesions. The mechanism of action is that it has high selectivity for progesterone receptors, because of which it creates a hypoestrogenic and a hyperprogestogenic environment, and it causes desterialization of the ectopic endometrial tissue, resulting in atrophy of the ectopic endometrial lesions. The mechanism of action is that it has both central and local effects. At the central level, which is at the level of hypothalamus and pituitary, it inhibits the gonadotropin secretion, and it causes moderate suppression of circulating estradiol. It also causes anovulation, and locally at the level of endometrial tissue, it has anti-proliferative effect, where it inhibits the proliferation of endometrial-like tissue. It has anti-inflammatory effect, it has anti-angiogenic effect, and also modulates the prostaglandin E2 expression. The rationale for using progestins or Dynogest in the treatment of endometriosis is that it reduces the serum estrogen levels. It has immunomodulatory effect. It has anti-inflammatory effect. It has anti-angiogenic effect. It causes desterialization and the atrophy of the endometrial tissue, and it inhibits the proliferation of the endometrial cells by modulating the expression of the matrix metalloproteinases and aromatase, which are involved in the ectopic endometrial response to endogenous estrogen. Comparing Dynogest with other progestins, Dynogest has a progestogenic activity, but it does not have a glucocorticoid or a mineralocorticoid activity, and it has a mild anti-androgenic activity as well. So it is given at 2 mg once daily dose, which can be started at any day of a menstrual cycle. Treatment must be continuous without regard for vaginal bleeding, and in the event of 1 or more missed periods, tablets should be administered as soon as possible, and we need to continue the therapy the following day at the usual time. The oral bioavailability is about 91%. It is metabolized by known steroid metabolism pathways. The elimination half-life is about 9 to 10 hours and is excreted mainly in the urine. The contraindications are active venous thromboembolic disorder, diabetes mellitus with vascular involvement, known or suspected sex hormone dependent malignancies, undiagnosed vaginal bleeding, presence or history of artery and cardiovascular disease, presence or history of severe hepatic disease, and presence or history of benign or malignant liver tumors. Moving on to other studies, a meta-analysis of all the studies, many studies show a beneficial effect in pain reduction by Dynogest. One study found marked decrease in pain with Dynogest, where the EAPP score decreased from 6.3 at enrollment to 0.9 at the end of 6 months with Dynogest. And a long-term study reported a VAS score decrease from 20 to 9 mm over treatment of about 65 weeks. The Visado study, which was the Visan study to assess safety in adolescents, found that 81% of them had pain relief from baseline over 24-week period. A long-term 52-week study of Dynogest showed improvement in the pain score in 72.5% of patients after 24 weeks and 90% of the patients after 52 weeks. Another study showed Dynogest effective in improving the quality of life by decreasing the AAPP in 78% of the patients. Not many studies have been done to see the effect of Dynogest in reducing the endometrioma size, but Ludovico Musi et al. Found reduction in mean cyst diameter from 4 to 2.4 centimeter at 6 months of Dynogest. And one study said that 75% volume reduction with Dynogest in 6-month period. And another study showed cyst disappearance in 76.5% of the patients at the end of 6 months of Dynogest use. So it is said that it was seen that Dynogest is effective in reducing smaller endometriomas, which was less than or equal to 4 centimeters. They responded better to medical treatment than the larger ones. And some studies also reported regression of endometriomas on prolonged usage. Dynogest has minimal side effects among all the agents which were used for endometriosis. The commonest side effects were abnormal uterine bleeding and a slight reduction in the bone mineral density. The Visado study concluded that at the end of 52 weeks, there was a marked decrease in the bone mineral density of about 1.2%, but it recovered partially after treatment cessation. Some of the other side effects but were well tolerated were headache, breast discomfort, depressed mood, acne, and each of them occurred in only less than 10% of the total women who took Dynogest. These were the various studies. And long-term Dynogest treatment beyond 1 year as a first-line treatment for endometriosis proved to be effective and safe. And ovarian chocolates is also markedly reduced by short-term use of Dynogest. So Dynogest was approved by the DGCI India in 2017 for the treatment of endometriosis. Dynogest in the dose of 2 mg per day had similar results as buserelin, buprolide, and triptorelin in reducing AAPP. It has lesser side effects with almost equal efficacy as GnRH agonists in relieving the symptoms of endometriosis. Long-term studies conducted till date have reported that its efficacy increases cumulatively with minimal side effects. So take-home message is that oral Dynogest can be considered as a safe and a first-line medical option in endometriosis, especially in young women who are desirous of preserving their future fertility. For many years, the primary use of medical therapy for endometriosis has only been as an adjunct or as a maintenance treatment following surgical diagnosis and surgical intervention. But there's been a recent paradigm shift that has occurred towards considering empirical medical treatment following the clinical diagnosis of endometriosis. As endometriosis is a chronic condition, emphasis has been placed on the necessity for long-term medical treatment to alleviate symptoms and in preventing recurrence. Thank you.
Thank you, Lakshya. That was presented very well. Thank Dr. Deepa to have invited us to give a talk on this present a journal article on benign gynecology. As soon as she offered us this topic, the first thing which came to my mind was endometriosis. As we all know, it is a disease of the adolescents and young people, young women of reproductive age, and 10 to 15% of women in the age group 15 to 44 years are affected by endometriosis. It's a chronic disease with severe life-impacting complaints of dysmenorrhea. Treatment is usually aimed at controlling the symptoms. And as we saw from the article which was just presented, more than 70% of the women in this study group presented with dysmenorrhea, which is very quite disabling to the patients during their day-to-day life. It was always a dilemma if these women should be treated for dysmenorrhea by medical methods or a surgical method. Earlier on, we were using danazol as a gold standard medical management, but due to its side effects, over the years, we have stopped using danazol, and now Dynogest has taken a front seat. And we have seen from this study that it has proven to be very effective in treatment of dysmenorrhea in this group of women. So I now call Dr. Ramani Devi, madam, to please give her expert comments on this article. Madam?
Just 1 second. Yeah, can you see me now? Can you hear me?
Yes, madam.
Yeah. Thank you for making me an expert for this particular topic. So the presenter has done a wonderful job by enumerating all the salient points what they should understand in an adolescent endometriosis. So the first thing is, in that study they have taken only 56 cases. That's a small series. So
Yes.
that may be the drawback. But they have in detail analyzed what are all the factors that has to be discussed, and they have done it in a wonderful way in this particular paper. So my only question to the presenter is, why in this particular study, as Dr. Uma had already mentioned, dysmenorrhea is the most important thing. See, we can just, now the recent guidelines that was published in 2024 says, we don't need any laparoscopy or imaging evidence. It is just the symptoms that are essential to diagnose endometriosis. That too, progressive dysmenorrhea in young girls. It is indicative of endometriosis. So, like, I am very fond of telling the symptoms of endometriosis are 7 Ds, that is dysmenorrhea, dyspareunia, dysuria, dystacia, diffuse abdominal pain, and then dysfunctional uterine bleeding, and infertility, that is difficulty in conceiving. So, any patient who has got only 2 signs of this endometriosis associated pelvic pain, we can boldly diagnose it as a case of endometriosis, even if they don't have an clinical, if they don't have an imaging evidence. So they have to be started on drugs. Now the question is, the ESHRE guidelines, they say progesterones are the first line or level A evidence, and the common progesterone and oral contraceptive pills which were thought to be used for endometriosis once upon a time, it is not gaining popularity nowadays because of the estrogen content. So the progesterone is found to be the level A evidence for treatment. So now I'm asking one question to the presenter: why all people, if you give 100 people dynages in adolescent endometriosis, will everybody respond to dynages? Where is the presenter? Yeah.
Lakshya.
Yes, ma'am.
Lakshya, will everyone who put on dynages, will they respond to treatment?
Maybe not everyone, ma'am, because
we can expect only 2/3 of these patients to respond. So the rest of the patients, they don't respond. Why they don't respond? What is the basic pathology? It is the progesterone resistance, which is very, very high in this group of patients, and they don't respond. So what will be the next choice of the drug instead of dynages in these young women?
Can we give oral contraceptive pills in semen or GnRH agonists?
What I am telling, no oral contraceptive pills. It will mask the deep infiltrative endometriosis, and it is not going to be of any use. Okay? It will not prevent the development. So the next one is only GnRH
agonists.
Analogs. Which drug do you prefer? Yeah, agonist you prefer. What is the disadvantage of GnRH agonist?
Long-term usage
for the young girls. What is the disadvantage?
Long-term usage can cause osteoporosis, ma'am.
The disadvantage is reduction in bone mineral density.
Yes, ma'am.
BMD reduction as well as vasomotor. So and there is one more thing is, how does the GnRH analog act, agonist act? It binds with the receptors.
Yes.
But there will be an initial flare-up effect.
Flaring, and then
so the patient will have exaggerated symptoms once when you started.
Yes,
so that has also got disadvantage.
Yes,
so what is the newly available drug which can treat girls with adolescent girls beyond 17 years or 18 years for their pain? GnRH analog.
Duration of the study?
Ma'am, it was between November 2018 to December 2019, like a year, ma'am.
It took a year.
Yeah.
There was no comparative, any other, it was a single drug.
Yes, ma'am. They just took a single drug and its effect. No, ma'am. They didn't compare it to any drug. Yes, ma'am. They just
what is
saw
the largest size of endometrioma?
8 centimeters, ma'am. Less than
So
8
those
centimeters.
did not respond.
Yes, ma'am. In less than or
Those did
equal to
not
4
respond.
centimeter responded. More than 8
Less than
centimeter
4 centimeter.
only
So that
responded.
is that we have to take into consideration when we are, prescribing any drug, any medication.
Yes,
What is
ma'am.
the size of endometrium? It's 8 centimeters. Anyhow, we
It's
were
not
going
going to
to
respond.
surgery, isn't
Surgical.
it?
Yes,
It's
ma'am.
not going to respond. So if it only if it is less than 4 centimeter, then the pain relief is there.
Yes, ma'am.
So I think that we really need to take into consideration. And of course, the
Yes, ma'am.
duration of therapy has to be more than 6 months at
Yes,
least
ma'am.
for the response.
Yes, ma'am.
Even for 6 months, it's not sufficient because once when you
Yeah,
stop the drug,
At
what
least,
happens?
that's what I said. At
Yeah.
least minimum. After that, even for a year, we may need.
So there are longest studies, like
Yes,
we can
ma'am.
use it for 5 years, continuously for 5
Continuous
years.
usage.
So when you use it for a longer time, maybe you will have a better
The cost
side
is
effect.
cost is a challenge, Dr. Ramani Devi,
Yes.
ma'am, for
Yeah,
diagnosis.
yeah.
Cost
Yeah.
is the challenge. Dr. Kiran, would you like to say something?
Yeah, excellent presentation. See, there always is going to be a fight between medical and surgical endometriosis with such a huge amount of surgery going on. So my question to the presenter would be, in deep infiltrating endometriosis, would you think that the medical management in a better way than the surgical management in India?
No. Sir, I think for medical management, it can be preferred in a younger girl or in any reproductive age women who were conserving fertility, sir. For fertility sparing, we can provide young women with diagnosis. Medical management is always preferred over surgical because surgical management can diminish the ovarian reserve. So it's always preferable for a young woman or any reproductive age woman who we want to conserve their fertility to start with medical management and then probably later see.
So coming to DOR that you rightly pointed out, was there any measurement of the AMH levels before and after administration of diagnosis? Any reports on the AMH levels fall after giving diagnosis?
Sorry,
Or the effect of diagnosis?
can go to the next session. If any
So the effect of Dynogest on AMH levels, especially when you give it for 6 months, has there been a study or what is your opinion or experience?
We haven't looked into any such studies yet, sir. I think that would be a good thing to look into.
Yes.
We haven't gone through it, sir.
Yes. So I think that again will point towards whether to do a surgical management or whether to do a medical management.
Yeah.
Yes.
Thank you.
So
Thank you.
there is a question in the chat box, like how
Yes.
long can a diagnosis be given to a young patient? Can it be given 2 years together? And if it is years together, for how many years? So that is a question in the chat box. So we would like the experts to go ahead and answer this question.
Actually, any kind of treatment for diagnosis should be at least for 6 months, at least for a period of 6 months. That is the reason why there are trials between long-acting GnRH agonists, that is depo presentations, versus Dynogest versus progesterone. And earlier, if you remember, say 20 years back when we were using Dinazole left, right, center. So the minimum time frame is at least 6 months. After 6 months, then you can decide depending upon the symptoms.
So is there a role for elagolix?
Yes, elagolix is a new drug which has come up and it has got a promising role. I don't know whether anybody in India is using that. I don't think so.
Yeah, true. So if there are no further questions, so can we move on to the second session? Thank you, Uma madam. Thank you. We would like you to stay
so
for
much.
the second session as well. So it is anywhere related to. So it is a pleasure to invite Dr. Kripa Hana Vaidyantam. She's a junior resident, Southern Railway Hospital, Chennai. The topic will be for HRACE guideline on endometriosis. She has a GNB resident there and a professional experience. She has been a obstetrician in CSC Jairaj Mission Hospital, Tirunelveli, as well as worked in Kotagiri Medical Fellowship Hospital, Kotagiri. So now she go ahead with that. Dr. Kripa, can you share your screen, please? So our Dr. Radha Rajeshwari Madam. Madam is the professor of obstetrics and gynecology in Southern Railway Hospital. So over to you both. Yes, we can see your slides.
You hear me, ma'am?
Yes, I can hear you. Yes. Is it possible to switch on your video?
Yes, ma'am.
If it's not possible, it's okay. If your network is poor, then you will not be able to, show your video and present. Then it's okay.
Yes,
we are able to see you, Kripa. Yes, thank you. Go ahead.
A very good evening to everyone. Over the next 15 minutes, we're going to go through the salient points published by ESHRE in 2022 on endometriosis. And I'd like to break down my presentation into the following listed topics. First is the clinical need and the magnitude of disease. Second is the guideline implementation strategy. And the third is what is new compared to the guideline that was published in 2014. And over the years, there has been a paradigm shift in the treatment of infertility. So we look at the changes that have been made. And this guideline addresses both spectrum of age groups, which includes the adolescents and menopausal women. And finally, we'll end with endometriosis and cancer. So like we already saw, endometriosis is defined as the presence of endometrium-like epithelium and or stroma outside the endometrium and myometrium. The estimated prevalence of the disease is 2 to 10% in the general population, whereas it can be up to 50% in patients with subfertility, which is quite a huge number. This guideline basically addresses the diagnostic void between the onset of symptoms and the clinical diagnosis. As we all know, endometriosis presents with two hallmark complaints, which is pain and infertility, which not only affects the quality of their life, but affects their partners and their families. Now, how did they come about this guideline? So this is the guideline developmental strategy that they used, which includes 12 steps. The first one being they selected the topic, which is endometriosis, and the guideline developmental group was formed. Scoping basically refers to identifying the lacunae in the existing literature. Finally, 42 key questions were formulated after finding out the lacunae in literature, of which 7 questions were addressed in a narrative manner and 35 questions were addressed in patient intervention comparison outcome. There was extensive evidence search that was done on all the database available. The evidence was summarized and finally recommendations were formulated, which were drafted for review and finally reviewed by the stakeholder, and the final approval was by the executive committee, and it was published in February 2022 on the 26th. So this guideline is up for updation in 2025. So this guideline was published in the Human Reproduction Open, which is ESHRE's journal, in volume 2022 and issue 2. So as we already said, they follow the systematic RAND modified Delphi method, and 2 questionnaire round was performed and a final agreement round was performed. And the draft was published for public review between the 24th June and the 15th August of 2021. And it was finally published on the 26th of February 2022. Now, what's new? What has changed over the years? The first thing is the diagnostic process of endometriosis. The second thing is endometriosis in adolescents and endometriosis in postmenopausal women. There has been a lot of changes that have come about in endometriosis-associated infertility when surgical management is indicated, and of the feasibility of medically assisted reproduction. And finally, they have also addressed endometriosis and cancer. So Dr. Ramani Devi already elaborated on the common symptoms that patients present with. But as we all know, endometriosis has a varied presentation, and we also need to look at the atypical symptoms that patients can present with, like shoulder tip pain, catamenial pneumothorax, cyclical cough, hemoptysis, chest pain, cyclical scar swelling, and pain, fatigue, and infertility. Now, is the symptom diary of any use? The guideline says that symptom diary only complements history taking but does not lead to early diagnosis. Now, coming to clinical examination, a bimanual and a rectovaginal examination is useful in diagnosing deep endometriosis, whereas clinical examination will not pick up superficial endometriosis. The diagnostic accuracy is quite low. Now, what diagnostic tests do we need to perform? So once a patient presents with the symptoms and endometriosis is suspected, imaging is recommended even if clinical examination is unremarkable. So what is the role of ultrasound and MRI? There are three types of endometriosis. The first one is peritoneal endometriosis. Ultrasound and MRI both have very poor sensitivity in picking up peritoneal endometriosis, whereas ultrasound has a 95 to 96% high sensitivity for picking up superficial and ovarian endometrioma, whereas MRI is an excellent tool to pick up deep endometriosis and when endometriosis involves the rectosigmoid. The use of biomarkers in blood or menstrual blood like CA-125 is not recommended. Now, when is laparoscopy used as a diagnostic tool? As we all knew earlier, laparoscopy was the gold standard, but what has changed is that laparoscopy is no longer the gold standard. There are two indications for laparoscopy. The first thing is when endometriosis is suspected, a two-step approach is followed. So when a patient comes with symptoms, you perform an ultrasound and treat them empirically. If there is failure to respond, then you offer laparoscopy. Or if there is response to treatment, then you presume as endometriosis and continue treatment. The second thing is laparoscopy is useful in providing tissue diagnosis. But the clinch here is a negative histology does not rule out endometriosis. So this is a summary of what I just said in the diagnosis of endometriosis. These are the signs and symptoms. A symptom diary can be helpful in history taking and objectifying the pain. Negative imaging does not rule out endometriosis, and biomarker testing is not recommended. If a patient presents with signs and symptoms, proceed with treatment. But once you commence empirical treatment, if treatment is unsuccessful, then you need to offer laparoscopy to explore for peritoneal endometriosis. And based on the symptoms, varied symptoms, further imaging may be required, like when endometriosis involves the urinary tract or the digestive tract. Now, the hallmark of endometriosis is pain, and the first line management as recommended by the guidelines is combined oral contraceptive pills and progestins. NSAIDs may be offered alone or along with hormone therapy. So combined oral contraceptive pills causes significant alleviation of pain. A continuous usage is preferred over cyclical usage because it not only causes amenorrhea, but homogenizes the hormonal milieu. Coming to the mode of administration, if the guideline recommends oral contraceptive pills if a patient presents with dysmenorrhea, whereas if they have dysmenorrhea, dyspareunia, and non-menstrual pain, oral ring or transdermal route can be used. Progestins, Dynogest is extensively studied, as we already saw, but the side effects are bloating, breast pain, weight gain, and intermenstrual spotting. But there is significant reduction of pain. The guideline says LNG IUS and etonogestrel implant is preferred over other progestins with similar clinical outcome. The second line is GnRH agonist. But what is new is the introduction of GnRH antagonists as a second line of management. GnRH agonist is inferior to LNG IUS, but it is also associated with a poor side effect profile. Like patients can present with hypoestrogenic symptoms like vaginal dryness, decreased libido, and you need to give add-back therapy. There is limited evidence on the duration of treatment of agonist and GnRH antagonists. The role of aromatase inhibitors is basically it is used only for refractory pain and can be used in combination with combined oral contraceptive pills, progestins, agonists, or antagonists. The role of laparoscopy in the management of pain. Basically, the technique that is recommended is excision over ablation. There is no role of laparoscopy in superficial endometriosis. A cystectomy is preferred over incision and drainage or any other technique because it decreases recurrence and pain. Cystectomy and laser ablation, when compared, late recurrence beyond 1 year was similar, but early recurrence was less with cystectomy as compared to laser ablation. Deep endometriosis definitely requires expertise and helps in alleviating pain. Laparoscopic uterosacral nerve ablation is not beneficial, and there are specific use for presacral neurectomy. It can be used as an adjunct to operative laparoscopy in patients with midline pain. This also requires expertise and is associated with side effects like bleeding, urgency, and constipation. Now, once treatment is a huge part of it, but prevention of recurrence is very important. Now, as we already saw, surgical technique, cystectomy is superior. For prevention of recurrence, medical treatment and LNG IUS can be inserted, or combined oral contraceptive pills can be given for 18 to 24 months. And in case of deep endometriosis, post-operative hormone therapy is recommended. Now, what is new here is preoperatively hormone therapy prior to surgery is not recommended, and post-operatively hormone therapy is offered to prevent recurrence and to manage immediate post-operative pain only if pregnancy is not planned. And physical therapy, exercise, and acupuncture have found to be no benefit. So this is summarizing the points that we had already discussed. Coming to the treatment of infertility. So there has been a paradigm shift in the management of infertility. In managing infertility, unlike management of pain, ovarian suppression preoperatively and postoperatively are not required, are not recommended. Pentoxifillin and letrozole are no longer used outside the context of ovarian stimulation. Now, in offering surgery, the guideline addresses two groups. The first group is patients with stage 1 and 2 revised ASRM. So the guideline recommends operative laparoscopy only for stage 1 and stage 2 because it improves spontaneous pregnancy rate. The role of laparoscopy in deep endometriosis, there is limited evidence, and one needs to keep in mind the age, symptoms, and the ovarian reserve while offering surgery. Now, endometriosis fertility index is a validated tool to counsel and predict the chance of achieving pregnancy, which is new, and in patients with stage 3 and stage 4. Surgery, when a patient is planned for ART, routine surgery prior to ART to improve fertility rates is not recommended as it can be detrimental to the ovarian reserve. But there are only two indications for surgery for a patient planned for ART. The first one is when endometriosis is associated with pain, and in the second indication is when difficulty in accessibility of follicles is anticipated. Fertility preservation is an option for patients with bilateral and stage 3 and stage 4 disease. Medical assisted reproduction. Revised ASRM stage 1 and 2, the first treatment that is offered is ovulation induction with IUI. In revised ASRM stage 3 and 4, what is concerning is the tubal patency. When tubal patency is uncertain, ovulation induction with IUI can be considered. The role of ART is confined to patients with tubal function, when tubal function is compromised, low EFI, and male factor infertility. Now, what protocol is better? the guideline says that agonist and antagonist protocols, the outcomes were similar and either of it can be used. And when a patient has ovarian endometrioma, antibiotic prophylaxis at the time of oocyte retrieval is a mandate. And what has been practiced over the years, prolonged suppression prior to ART, the guideline refrains from commenting and says that the benefit is uncertain. Now, coming to the impact of pregnancy, impact of endometriosis on pregnancy. Pregnancy is not advised with the sole intent to treat endometriosis. And in the first trimester, one needs to watch out for miscarriage and ectopic pregnancy. There is limited data on the association with GDM, preterm labor, placenta previa, and abruption. However, increased antenatal monitoring is no longer required. Summarizing infertility, hormone treatment, as we already saw, is not recommended anymore. Now, addressing endometriosis in adolescents. Coming to the history, a clinician needs to suspect endometriosis in patients with short menstrual cycles, obstructive genital malformation, family history of endometriosis, or cyclic absenteeism. The main complaint that they come with is pain, and transvaginal ultrasound can be offered where appropriate. The other options that are available are MRI, transperineal, transabdominal, or transrectal ultrasound. And the guideline states that on laparoscopy, what you need to look out for, apart from the usual appearance of endometriosis, is atypical red or clear lesions. And coming to the management, hormone contraception, progestins, and LNG-IUS is the first line of choice. And GnRH agonist is the second line therapy. And it is safe up to 1 year because the critical window for peak bone mass index is in the adolescence, and add-back therapy is required. Surgery is offered only for failed medical management, and you need to follow them up with hormone therapy to prevent recurrence. Now, is oocyte preservation required in adolescents? Adolescents undergoing surgery ought to be informed of the detrimental effect on the ovarian reserve and future fertility. It is a reasonable option prior to surgical intervention. The benefits, safety, and indications are still unclear. Now, endometriosis and the other spectrum, menopausal women. We all know that endometriosis is steroid dependent and is expected to regress in the menopausal period. The incidence is 2 to 5%. However, data is very scarce. And what is new here is endometriosis can be active after menopause. It has a complex pathogenicity. The source of estrogen can either be from a peripheral conversion or the existing endometriotic lesions that can produce estrogen. Now, how is treating endometriosis different in menopause? The first option that you can give is surgical treatment in patients who are symptomatic with endometriosis to enable histological diagnosis, as there is always an uncertainty in the risk of malignancy. And whatever treatment is offered, oncological principles must be kept in mind. And women with endometriosis inherently are at an increased risk of have an increased cardiovascular risk, irrespective of whether they've had a surgical oophorectomy. Medical management comes second in line, and aromatase inhibitors can be considered. Now, how do we deal with patients with endometriosis who present with menopausal symptoms? Now, the most common symptoms in menopausal symptoms that warrant therapy is vasomotor and urogenital atrophy, and combined menopause hormone therapy can be used after surgical or natural menopause. Tibolone is also an alternative, which is estrogenic on the bone and vasomotor symptoms and have progesterogenic effect on the endometrium. Now, patients who have undergone surgical menopause come, unlike patients who already have had hysterectomy for other reasons, who require only estrogen. Patients with endometriosis require combination of estrogen and progesterone till the natural age of menopause. Caution needs to be exercised, and estrogen only regimen needs to be avoided as it increases the malignant transformation. Now, how do we deal with patients who present with asymptomatic endometriosis? Clinicians ought to inform any incidental finding of endometriosis. Surgical excision and ablation are not recommended. In the absence of evidence of disease progression, medical treatment is also not warranted. But routine ultrasound monitoring is required. The duration and the frequency, both are which not, the conclusion has not arrived yet. Finally, we're going to deal with, we're going to see endometriosis and cancer. As we can see, there is almost a double increase in the chance of ovarian cancer. And most commonly, they present with clear cell carcinoma, which has poor prognosis. And there is also an increase in the risk of breast and thyroid cancer. This is a diagrammatic representation. And coming to colorectal cancer, the risk is the same as in women without endometriosis. But cervical cancer, they found that the risk was lower, which was validated because patients with endometriosis are generally symptomatic, and they present and they have regular screening, which is and we are able to pick up pre-malignant lesions. So for prevention, avoid smoking, maintain a healthy weight, exercising regularly, balanced diet and high intake of fiber, low intake of alcohol, and using sun protection protects against cancer. Cancer screening is in accordance to general population-based screening guidelines, and cancer screening, according to the local guidelines, is considered in patients who have additional risk factors like a strong family history or specific germline mutations. CA125 and sonography has no benefit in early detection or in reducing the mortality for ovarian cancer. So to summarize, we'll touch upon the 5 topics that we discussed. The first thing, diagnosis, laparoscopy is no longer the gold standard. In adolescence, we need to bridge the gap between the onset of symptoms and the diagnosis. And in fertility, ovarian suppression is avoided. You need to balance between surgery and ovarian reserve. And in menopausal women, endometriosis can be active, and you need to offer menopause hormone therapy. And coming to cancer, there is a slight increased risk of ovarian carcinoma. Thank you.
Sipa, that was a very nice presentation. You reviewed the guideline very in a clean manner. Thank you. Over to Dr. Rajarajeshwari. Your team has done a wonderful job.
Madam, thank you for giving.
We couldn't able to hear Raji. Dr. Kiran.
Yeah. Overall, very nice presentation. Yes, she has covered all the aspects. Now only, yeah. So you said that laparoscopy is not the gold standard.
Kripa.
Yes, sir.
Kripa, madam, you said laparoscopy is not the gold standard. So
Yes,
it
sir.
wipes off all the information or all the things which have been taught to us in the last 30 years.
Yes, sir. A lot has changed, and now I think we'll have to adopt to the new guidelines, sir.
No, I agree, but for people like us and Surekha, probably it's difficult. So you please tell me how to diagnose a peritoneal window. How is it possible? So we can't say that only a laparoscopy is wiped off, because laparoscopy is going to be one of the standards. Anyway, so you tell me, how are we going to diagnose a peritoneal defect? How are we going to endometrial thickenings.
Can you hear
How
me,
are
sir?
we diagnose uterus thickening? How are we going to diagnose the Kurz peritoneal jelly?
Sir, can you hear me?
Yes,
Yes, madam.
yes,
Rajeshwari,
yes,
madam,
Dr.
yes, I
Rajeshwari.
can hear you.
Yeah.
No,
Now
again,
we lost you again, Rajeshwari madam. We are not able to hear you again.
She starts, we hear her, and then suddenly we lose. Something is wrong with the network.
The network is not good.
No, we can see her well. These guidelines are based on a lot of research. I think more research is required because see, if you say laparoscopy is not the guide, no longer the gold.
Yes, ma'am. They have
What is the
addressed
gold standard then?
sound mute.
Yes,
Can
ma'am.
you
We
hear
are
me, ma'am?
hearing you.
Yeah.
Yes, yes.
Yeah. They have addressed all these issues separately, ma'am, in this guideline. For diagnosis, what they are saying is no need to use laparoscopy as the gold standard. But for infertility, they're saying at 2. I have a small presentation. Can we finish this and have the discussion? Like
Yes.
I have, yeah. For completion's sake, I've put a small presentation.
Yes, madam. Yes.
till the time you are live, I mean, what is the opinion between dydrogesterone and dynogest? Because dydrogesterone now is in 30 milligram tablet for the same indication, that is endometriosis.
The guidelines doesn't compare between different products of progesterone, sir. They have just said that hormonal contraceptives, LNG IUS, are the first line, especially combined oral contraceptives. Yeah, I've just made a small presentation. Thank you for the opportunity. So I have chosen this topic of endometriosis because for 2 reasons. One is that we wanted to bring out how a guideline is being formed, first thing. Second thing, endometriosis is a disease of dilemma for the clinician. At every stage, we have a dilemma, whether to do or not to do. So most of the points has been addressed by Dr. Kriba. I will quickly go through some of the aspects which has been highlighted in this guideline. The first thing is medical therapy as an adjunct to surgery. Do we do a surgery and whether we don't know whether to give a medical therapy which is beneficial or not. So the purpose of medical therapy as an adjunct to surgery is 2. One is to improve the immediate surgical outcome. And second is for secondary prevention. And Dr. Kriba has already said that there is no role for giving medical therapy in the preoperative period. For preoperative period, if you're giving a medical therapy, it's not going to solve the purpose. These 2 purposes is not going to serve. Only we can give preoperative medical therapy to reduce the pain in the waiting period. So in the postoperative period, if you're giving a medical therapy starting medical therapy within 6 months, the short-term therapy, this is mainly to improve the immediate surgical outcome. And we have to give more than 6 months as a long-term therapy for secondary prevention. Endometriosis associated pain. What is better, hormone therapy or surgery? So in this guideline, they have highlighted that we still do not know whether surgery or hormone therapy is good, which benefits over the other for women with endometrioma. There is an ongoing RCT called the SOMA trial. It's yet to come. So until then, it is a shared decision making between the patient and the treating doctor. What about DLAP for endometriosis? Should we really do a DLAP? Because we are already told that laparoscopy is no longer the gold standard. As Dr. Kriba was saying, there are 3 types of endometriosis. One is the superficial or the peritoneal endometriosis. Second is the endometrioma. And third is the deep endometriosis. So the way the endometrioma and the deep infiltrating endometriosis, we have imaging modalities to pick up. But the superficial or the peritoneal endometriosis, there is no modality to pick up. So that's what they have highlighted in this guideline. They've said that no need to do a laparoscopy just to diagnose
this. You directly go and start therapy. If the patient responds, it means that it is endometriosis only. There is no need to do a invasive procedure for just to diagnose endometriosis. But what about the role of diagnostic laparoscopy in an infertility workup? The verdict is still to come. The role of diagnostic laparoscopy in the context of fertility workup will be covered in the assured guideline on NX line infertility. It is under development. So in this guideline, they have highlighted the use of, asked us to use the endometriosis fertility index, EFI. So this EFI, I just put up this surgical form for all of us to follow, because the time and again they've emphasized in this guideline. This endometriosis fertility index has two scores. One is the historical score, the other is the surgical score. The first thing is the least function score. This is what we see during surgery, at the conclusion of surgery. After finishing the surgery, we have to put the least function score. We have to get a total, both on the left side and right side, you have to see, it's an anatomical description. You have to get an LF score. And the other score is based on the historical factors. Points are given for the historical factors. And the surgical factor, apart from the LF score, we have to use the American Fertility Society endometriosis score. The total score and the endometriosis score both has to be used, and historical score and surgical score has to be added up, and we have to get a EFI score. The EFI score index, if it is high, it means that this mainly, EFI index is main thing is to predict whether that patient will need an ART or there is a chance for natural conception after surgery. So to predict the outcome of surgery, this EFI is going to help us in many ways. First thing is the EFI score is high. That means that they have high chances of having a natural conception or IUI after surgery. If the EFI score is low, then these patients has to be advised for ART. So the issued guidelines has said to identify patients that may benefit from ART after surgery, the EFI score should be used as it is validated, reproducible, and cost-effective. So we all know that endometriosis is a steroid-dependent condition, but in ART we are using a lot of hormonal products. So what if does ART increases the risk of recurrence or worsen pain symptom? This is one question that always comes in our mind. So this guideline addresses that women with endometriosis can be reassured regarding the safety of ART, since the recurrence rate are not increased compared to those women who are not undergoing ART. So ART does not increase the recurrence rate or worsens pain. Regarding recurrent endometriosis, how? Already we have given hormone therapy, we have done surgery. How should patients with recurring endometriosis or recurring symptoms be managed? Can repetitive surgery be done for endometriosis? So the guideline says any hormone treatment or surgery can be offered to treat recurring pain symptoms in women with endometriosis. For endometriosis and menopause, we already know that BSO, bilateral salpingo-oophorectomy, as a standard treatment, and this is associated with increased risk of diminished bone density, dementia, and cardiovascular risk. We already know that. But per se, as with endometriosis itself, without even an early surgical menopause, there is an increased risk of cardiovascular disease. This is new to us. What about extrapelvic endometriosis? For abdominal extrapelvic endometriosis, surgical removal is the preferred treatment. Hormone treatment may also be option when surgery is not possible or acceptable. For thoracic endometriosis, the first line is hormone treatment can be offered. If surgery is indicated, it has to be performed in a multidisciplinary manner with the cardiothoracic surgeons. What about primary prevention? That this primary prevention comes. See, we all know that endometriosis has a genetic predisposition. The first degree relatives want to know whether they can do something to prevent getting endometriosis. So this guidelines has assessed many evidence and studies regarding whether healthy lifestyle or diet or reducing alcohol intake or regular physical activity, whether it helps for endometriosis. And they have found that smoking alone smoking cessation doesn't have any benefit on preventing endometriosis, but a few studies have shown there is some benefit in preventing endometriosis. So, but these are all not strong evidence. So the guidelines says, although there is no direct evidence of benefit in preventing endometriosis, women can be advised all these measures aiming for a healthy lifestyle. And what about hormonal contraceptives? Do they have any role in primary prevention? Small studies have shown some benefit, but since there are no RCTs or stronger evidence, the guidelines say the usefulness of hormonal contraception for primary prevention of endometriosis is uncertain. What about the impact of hormone treatments? Now, Dr. Kripa already said there is a slight increase, the absolute risk, increased risk for cancer in endometriosis patients. First thing is ovarian cancer. In the ovarian cancer, both clear cell and endometrioid carcinomas can occur. And then they have slight increased risk for thyroid and breast cancer. So what we are using a lot of hormonal treatment for endometriosis. Does this increase the risk of cancer? So from the robust, strong evidence is there that ossipals have been used for general population. They have extrapolated to bring out this guideline. The robust evidence from studies in the general population shows that the risk of ovarian, endometrial, colorectal cancers are decreased in women who use ossipals. Risk of breast and cervical cancers are increased while using hormonal treatment. However, as already highlighted by Dr. Kripa, the cervical cancer seems to be relatively lower in patients with endometriosis, and the ossipal-induced increased risk of cervical cancer is being mitigated, counterbalanced here. And the risk reduction for ovarian, endometrial, and colorectal cancers may outweigh the increased risk for breast cancer. The risk reduction and risk increases, whatever benefit and risk increased is more pronounced if the ossipals is used for longer durations. Thus, surgery. We have seen whether hormone treatment affects risk for cancer. Now we'll see whether surgery can produce any change in the future risk of cancer. The surgical excision of endometriosis from the ovaries or from any other locations may reduce the risk of subsequent ovarian cancer. Removal of affected ovary, where appropriate, may have a bigger cancer risk reduction than excision of the disease and preservation of the ovary. They're saying whenever it is appropriate, it is better to remove the affected ovary rather than just excision of the disease. If endometriosis involves both ovaries, BSO can be considered with caution regarding to the long-term health risk. This has to be considered. Whenever appropriate, it's better to do a BSO to reduce the risk of cancer. And this guideline has, in the starting introduction itself, has given a disclaimer. The clinical practice guidelines do not override the healthcare professionals' clinical judgment. Thank you.
Over to Kiran, sir.
So the last slide was good.
Yes, sir. I know.
No, but really, I mean, I would appreciate the efforts which you have taken to study the topic in depth, and really appreciate your efforts in person, because you have taken the efforts to prepare the slide presentation after your after the talk of your student. So great. Thank you so much. I think, over and all, we cannot brush aside laparoscopy, because laparoscopy still, I feel, in my opinion, should be the gold standard. Because see, especially when you are treating a patient for infertility, after three cycles of, say, failed IUI or failed ovulation induction.
Sorry to interrupt. They have said only for diagnosis, don't use laparoscopy, diagnostic laparoscopy to diagnose the disease. But for treatment, laparoscopy is the mode of surgical method. They're asking,
Yes,
if somebody doesn't know laparoscopy, better to refer to a center which has expertise in doing that.
Okay. Anyway,
and for infertility patients also, they have divided into two groups. People who require ART and people who don't require ART. For people who don't require ART, for stage 1 and stage 2 ASRM, according to ASRM guidelines, if they are in the stage 1, stage 2 endometriosis, for them, laparoscopic surgery is beneficial. For stage 3 and stage 4, there is only limited evidence. For people who are for ART, there only they are saying don't do laparoscopy because it may reduce the ovarian reserve. In people who are for ART, there are only two conditions why we have to do. One is for pain, the other is to if you are having a difficulty in assessing the follicle. So they are very clear in oral laparoscopy. They have not brushed laparoscopy aside. In fact, they have highlighted for deep endometriosis, they are saying that if you're not able to manage, if you don't have the expertise, don't do the surgery. You send to a center who are dealing with deep endometriosis, who have expertise in dealing with deep endometriosis. To them only you send. Don't do a surgery for doing a surgery's sake.
Completely agree with you. And we all know that Dr. Kiran sir is such an expert who can do deep endometriosis surgery. So that is why sir wants to come and give his opinion on that. So he can just give you our take home points. Yes, sir. We're waiting to hear from you.
Yeah, very well said. I think I must reiterate what Dr. Kiran Kirkoti has said, that a lot of efforts have gone into both the presentation and sub-components are clear, but it does take time, what we have been taught over the years, and again to look at the evidence, and again to, look at the guidelines and go step by step. It does take time to assimilate, and you have taken the effort, so appreciate that. Thank you.
I think what is important is we must customize treatment for each patient. It's not just follow guidelines, just customize it for each patient based on her presentation and future fertility options, whatever else you may want.
Yes, agree to that. Of course, endometriosis is a condition which will baffle quite a few of us, definitely with wide range of presentations, and the response is different in different patients. So we have to take into consideration all these things and rightly said, individualize.
So there is a question in the question and answer session for sir. If the Dynagest is being used for 6 months, okay, should we take breaks in between and then restart it or resume it when the symptoms appears? So they say do we need to give any break in between, for years together? So give it for 6 months, then give a break of 2-3 months, then start it, or can it be continuously given for years?
Continuous. It has to be continuous.
Okay.
See, for example, again, going back to 30, the best treatment for endometriosis for pregnancy. Why? Because pregnancy is a term which is for 9 months minimum. After that, breastfeeding again add 2 to 3 months of amenorrhea. For at all, 1 year of amenorrhea at least.
Yeah.
There is one question. Okay, so this Dynagest is going to suppress the ovaries for a longer time. So will it affect infertility once we start a stimulation, sir?
It will affect the infertility, definitely yes. That is why one of the guidelines that should be told is, before starting anybody or treatment on whether medical or surgical, first do a AMH level of that person. Number one. Number two, do the day 2 H and FSH levels also. Number 3, do the day 2 antral follicle count also, so that the patient is fully aware of the fertility status before the procedure, either before the surgery or before the medical management. And once the medical management gets over, once they visit, again all these points, that is day 2 levels, AMH levels, and antral follicle count on day 2, they all should be evaluated again, so that the patient herself will understand whether there is any loss of fertility. And of course, yes, once the endometrium is treated, the amount of gonadotropins is likely to be higher, slightly on the higher side.
Thank you, sir. Any other questions, Priya?
No, ma'am, no. So I would really like to thank Kiran sir. It was such a pleasure to have you here. And Dr. Sureka madam, thank you for joining us. And thank you, Dr. Uma madam and Dr. Rajarajeshwari madam, for accepting to be the moderators for today's session, and we had such an elaborate discussion on endometriosis, and definitely with so many take-home points and very informative session. So I think the postgraduates are going to really be benefited, and even the young consultants who have joined here today. So thank you, everyone. So we have a quiz followed by this session. So it is it is in the same Zoom platform. We'll be having the poll. So it is for everybody. It's not only for the postgraduate. So whoever is having time and extra time, just come and attend our quiz. And this was actually meant to happen in the last clinical research committee, directly in person CME. But because of want of time, we could not do that. And so we have brought the quiz in the journal.
Yeah. Priya, we need to do the quiz on a national level. As
yes, ma'am,
promised,
definitely.
We did have a physical meeting, sir, in Chennai of Clinical Research Committee, and Priya and all the Chennai
Oxy people. Yes, ma'am. And we were
but we didn't finish the quiz. So next time you please arrange the quiz.
No,
Sure,
that's
ma'am,
only we are doing it a poll here, madam.
Yeah, today we have brought it as a poll today. We will arrange for a quiz next time when we have it, madam. And that time we will make sure that the program runs on time, so that the quiz doesn't get cancelled like this.
Yeah, thank you.
Thank you, ma'am. Thank you. So, Sahiti, can we have the questions for the quiz, please?
Yes, ma'am. Yes, ma'am. First question.
Yes. What is the use of antimicrobial stewardship? It promotes the appropriate use of antimicrobials, improves patient outcome, augments the microbial resistance, decreases the spread of infection caused by multi-drug resistant organisms.
Ma'am, what's the time limit, ma'am?
Can we keep it as 20 or 20 seconds?
20 seconds enough.
Yeah,
Okay.
yeah.
Okay.
Host and panelists can't vote. It's only for delegates.
Ayyo.
That's
what I'm trying.
Yes, ma'am. Only for delegates.
Only for delegates. Go back to the delegates link and come and vote.
5 more seconds.
Okay.
Time up.
Thank you.
Second question.
Second question, you can go. The 4 Ds of optimal antimicrobial therapy are all except the right drug, the right dose, dangers of the drug, de-escalation of the pathogen-directed therapy. E is right duration of therapy. So one of this is not the right D. There are only 4 Ds. So the one we have formed is my own imagination D. So this was the topic of that seminar. So it would have been very easy if you attended and then attended the quiz. But for persons who have attended that, it's easy. Yes.
Time up.
Okay. So the next
Third
question. Third question. According to the CDC, core elements of AMS are all except antimicrobial stewardship is accountability, action, tracking, reporting, education, root cause analysis. So one of these is not the core element of antimicrobial stewardship. So for people who work in a place where it is your NABH accreditation, you have this antimicrobial stewardship. So whenever you are escalating and going on a higher drug, they come back and tell you whether you should use it or not. So these are all the points in that.
Last 2 seconds.
Yes.
Time up.
Question number 4. A patient with diabetes develops a UTI, which gets complicated with hypotension that is resistant to IV fluid. Which of the following antibiotic can be used? Piperacillin tazobactam, amoxicillin clavulanic acid, ceftriaxone, nitrofurantoin. So it indirectly says it is a severe infection.
Last 5 seconds. Time up.
Yes. Next question. Question number 5. 27-year-old multiparous with a spontaneous rupture of membrane at 37 weeks she is a GBS carrier in vaginal swab. What is the most appropriate therapy? Avoid spontaneous labor and give antibiotic prophylaxis. Offer 1 dose of antibiotic before an elective cesarean section. Offer induction of labor after 24 hours and IAP. Offer induction of labor immediately and antibiotic prophylaxis. So this is the RCOG guideline we are asking. So
Last
what is
2 seconds.
recommended?
Timer.
Yes. Next question. Question number 6. Dash is the most common bacterial pathogen isolated in urine samples from pregnant women. Klebsiella, Escherichia coli, Pseudomonas, Enterococcus. So if anyone who have worked in the OPD, you will definitely get this answer correct.
Last 5 seconds. Timer.
Okay. Question number 7. The urinary tract infection is one of the most common perinatal complications affecting approximately dash percentage of the pregnancy. 40%, 8 to 10%, 25 to 30%, 15 to 20%.
Last 5 seconds. Timer.
Yes. Question number 8. Complication of ASB includes all except asymptomatic bacteria, includes all except preterm birth, low birth weight, preeclampsia, sepsis.
Five more seconds. Timer.
Yes. Ninth question. Pyelonephritis occurs most frequently in the first trimester, second trimester, third trimester, postpartum.
Five more seconds.
The question number 10. Regarding acute cystitis, choose the wrong statement. As per the ACOG, ACOG recommends empirical treatment with ampicillin or amoxicillin, diagnosis by urine culture with 10 to the power of 5 colony forming units per ml, antibiotic treatment for 5 to 7 days. Clinician may consider repeating the urine culture 1 to 2 weeks after completing the treatment.
Last 5 seconds. Timer.
All the following women are more prone to have asymptomatic bacteria except alpha thalassemia triad, beta thalassemia triad, sickle cell triad, hemoglobin C triad, spinal cord injury.
Five more seconds. Timer.
Which of the following has the least sensitivity in the diagnosis of UTI in urine routine examination? Urinary nitrites, leukocyte esterase, WBCs, bacteria, a protein of 1+. So these are the urine routine when you do, these are the findings.
5 more seconds. Time up.
Thank you. Question number 13. The Rome 3 criteria for functional constipation include all except straining during at least 25% of the defecations, sensation of incomplete evacuation for at least 25% of the defecations, sensation of anorectal obstruction or blockage for at least 25% of the defecation, manual maneuvers to facilitate the evacuation defecation, either digital or supporting the pelvic floor, fewer than 5 defecation per week, which is not the criteria of Rome 3.
5 more seconds. Time up.
The hormone responsible for constipation are all except progesterone, somatostatin, motilin, relaxin.
Five more seconds. Time up.
The treatment of constipation pregnancy include all except bran diet, anticholinergics, laxatives, probiotics.
Five more seconds. Time up.
The circumstances that warrant a prompt referral to the gastroenterologist are all except a change in the bowel habit for longer than 2 weeks, rectal bleeding, known history of inflammatory bowel disease, a family history of colorectal cancer.
Last 5 seconds. Time up.
Which is a false statement regarding hyperemesis gravidarum, defined as severe vomiting with a weight loss of more than 5% or ketosis. In severe cases, if inadequately or inappropriately treated, hyperemesis can cause Wernicke encephalopathy or central pontine melanosis. Peak incidence is between the 11 to 14 weeks. Severe hyperemesis have a higher incidence of intrauterine growth restriction, which is a false statement.
Five more seconds. Time up.
Question number 18. Findings not observed in hyperemesis gravidarum are hyponatremia, hypokalemia, hypochloremia, hypothyroidism, ketonuria.
Last 5 seconds. Time up.
Question number 19. Wernicke encephalopathy is due to vitamin B1 deficiency, vitamin B2 deficiency, vitamin B6 deficiency, vitamin B12 deficiency.
Last 5 seconds. Time up.
Question number 20. Choose the wrong statement. Both severe hyponatremia and its rapid reversal may precipitate central pontine myelinosis. Double saline may precipitate Wernicke encephalopathy. If women with severe hyperemesis, corticosteroid therapy may produce a dramatic and rapid improvement. Hyperemesis causing Wernicke encephalopathy is associated with fetal death in 40% of the cases.
Last 5 seconds. Time up.
Regarding appendectomy in pregnancy, choose the wrong statement. In the pressure during laparoscopy should be maintained below 12 millimeters of mercury. Cesarean section is usually performed along with appendectomy. Appendicitis may result in preterm labor. The miscarriage rate is 10% in pregnant women operated in the first trimester.
Last 5 seconds. Time up.
Question number 22. Risk factors for SSI are all except hypertension in pregnancy, hair removal, skin preparation, previous cesarean section, elective cesareans, surgical site infection. What are the risk factors?
Last 5 seconds. Time up.
Regarding surgical infection prophylaxis, all are true except single dose of antibiotic at the time of induction of anesthesia or the surgical incision, redosing if prolonged surgery of more than 3 hours or if the blood loss of more than 1500 ml, higher dose in obese women. Prophylactic antibiotics are not indicated in diagnostic laparoscopic ovarian cystectomy for simple cyst and laparoscopic sterilization.
Last 5 seconds. Time up.
Regarding the surgical site infection, identify the wrong statement. Alcohol-based chlorhexidine is the first choice option for antiseptic skin preparation. Double gloving reduces the risk of SSI. Negative pressure wound therapy is shown to lower the SSI. In case of incidental bacterial vaginosis diagnosed before surgery, it is advisable to treat it for 5 to 7 days.
Last 5 seconds. Time up. Last question.
25. Identify the wrong statement regarding UTI. Recurrent UTI can be defined as 5 or more episodes within the 12-month period. Uncomplicated UTI occurs in urinary tract stones, duplex collecting system, or neuropathic bladder. Women with recurrent UTI should be advised to void after sexual intercourse. Postmenopausal women can be prescribed oral or topical estrogen, shifting the vaginal flora from pathogenic enterobacteria to the protective lactobacillus.
Last 5 seconds. Time up.
So we have come to the end of the quiz. I think if you give us some time, I think Sahiti will be able to give us the scoreboard, right?
Ma'am, since there are 25 questions, it will take more time.
No issues. So Deepa madam, are you there? Deepa ma'am? Not sure whether she's there. Okay. So we come to the end of the session. So the quiz results, we will be informing you in the groups. We'll be posting it in the Oxy groups, the winners. I hope you have all entered your right name so that, you know, like the person who is participating will be giving the results. So thank you, everyone. Thank you for attending the quiz and the talk. And it was a pleasure having all of you. And it was such an elaborate talk on endometriosis. I would really like to thank all the experts and the moderators. Thank you, Uma madam, for staying with us. Thank you very much. Thank you, Dana madam, for joining. So I could not see any other names. So thank you, Dr. Rajarajshri madam, for staying back. So thank you, everyone. And I would really like to thank Shield Pharma for the platform and also for the arranging with the quiz. Thank you all.